All right, good afternoon. Welcome to the lunch symposium. I'm Preston Sprenkle. So I do have some disclosures. I'm a PI for Progenics Pharmaceuticals on a couple imaging studies, and obviously doing this, speaking for Augmentics today. So a quick overview. I'm going to talk about why to use a prostate rectum spacer, what are the indications for this, and then what is the SpaceOAR Hydrogel. There are some clinical trials, and we'll go over those results and then review the application of the hydrogel, what are some of the reimbursements and the Yale experience, and then some conclusions. So as many know, prostate cancer is the most common cancer of men, with incidence of about 161,000 men proposed to be diagnosed this year in 2017, with a mortality expected of almost 27,000 men this year. Radiation is a common treatment, as we've seen in several of the presentations from this morning. There are several different types of radiation treatment, and these continue to evolve with the goal of decreasing the toxicity. However, there still are significant complications, including urinary complications, GI complications, and sexual complications as well. So what is the organ at risk? So the rectum has been really the dose-limiting factor for radiation treatment, with rectal toxicities and complications such as bleeding, rectal frequency, rectal urgency, pain, and development of fistulas being really significant complications, especially long-term potentially. And this is associated with a pretty significant loss of quality of life. In some of the pictures there you can see on the right where the radiation dosing typically goes into some of the rectal vault and some of the radiation changes that we see in the rectum on colonoscopy or sigmoidoscopy. So radiation exposure to the rectum is inevitable without some form of prevention. You can see on the left, let's see if I can move this here. With the normal anatomy, the prostate sits very closely to the rectum, and if we have a margin of radiation around the prostate, the rectum will definitely be involved. With a rectal spacer, this allows us to push the rectum away from the prostate, to allow that margin around the prostate to not affect the rectum. This also, one of the reasons that we need this enlarged radiation treatment field around the prostate is to account for movement of the prostate during treatments. Several large studies have demonstrated that even with hypofractionation or decreasing the number of treatments, which is a trend these days, there still is pretty significant rectal toxicity or grade 2+ GI toxicity, ranging anywhere from about 14% to 25% across these different studies. So then what is the hydrogel? How do we affect or create this rectal space? So it's a system that's intended to temporarily position the anterior rectal wall away from the prostate during radiotherapy. And it creates this space in the intent to reduce the radiation dose that is delivered to the anterior rectum. It did receive FDA clearance in April of 2015 and has been studied in several clinical trials to date over the previous couple years. It temporarily positions the anterior rectal wall away from the prostate, creating a space of approximately 1 to 1.3 centimeters. And this reduces the radiation dose that is delivered to the anterior rectum, and hence the resulting rectal and urinary side effects, as well as potentially loss of sexual function. So how does this prostate rectum spacing work? So there is a diagram on the left. You can see the prostate, the rectal wall, and then the spacer in the perirectal fat between the prostate and the rectum. Pre-implant MRI imaging shows the close proximity of the rectum and the prostate. After injection, about 3 months post, you can see this white hypoechoic area that is the hydrogel, which is displacing the rectum posteriorly away from the prostate. And then at 6 months later, the hydrogel has resorbed and there is no longer that filled space. This is a very interesting polymer. So it initially is a liquid, and I'll sort of show the kit, but when the polymer mixes, it creates a solid, and then that is broken down by hydrolysis over a 3 to 6 month time period, which results in its resorption. So the application itself is usually injected with an 18-gauge needle. It is initially a liquid. It needs to be injected continuously so it doesn't solidify in the needle. It usually solidifies within about 10 seconds, and it can last 3 months, absorbs within 6 months. It's a water-based polymer, so it does not heat up during polymerization. It's able to break down via hydrolysis, and it flows through the perirectal fat, which is able to lock it in place within the fat as kind of a superstructure. Just sort of more detail about it, it's a water polyethylene glycol hydrogel. It is used in many medical products, including artificial tears, prescription drugs, and medical implants. So while it is synthetic, it is biocompatible and non-toxic and safe. The procedure is done as an outpatient, and it can be done either with local, regional, or general anesthesia, depending on patient preference and your ability in your hospital to perform it. And then the 1 centimeter space for 3 months really allows for dose escalation and hypofractionation. So there's almost a 3/4 reduction in the rectal toxicity of the V70 with minimal long-term toxicity. So what are some of the values of this? Why use this? Well, it provides a treatment option for recurrence. So potentially, if we're able to spare the rectum completely from radiation, it may allow for re-radiating the prostate. It does enable dose escalation because there can be reductions to allow for reductions in cancer recurrence. It does reduce the rectal dose and rectal complications, and may allow for shorter treatment protocols because of the dose escalation that is possible and the hypofractionation that is also possible. So this is the kit. There is an accelerant. There is the polymer, which is mixed. It comes as a powder. You mix it up with the activator, and then put those two together. I'm not going to go over all the details, but there's also a 18 gauge needle here that's 15 centimeters in length for the application. It's relatively straightforward to put it together, and ultimately the kit, it looks like for those who do kidney surgery or with some tissue, it's a similar kind of idea with 2 syringes that mix the fluid as it goes into the needle. The setup is typically done in a dorsal lithotomy position because we're using a truss-based endorectal probe similar to a brachy setup for transperineal access. So really it's just skin prep and local anesthesia supplies. Nothing major is required. Need a little bit of saline as well as local, and the spinal needle to inject for the nerve block. Typically when I do this, so far most of our patients, which I'll get to in more detail, have been done in the OR just for technical limitations to do it in our outpatient clinic, but just give local anesthesia and a peripheral nerve block to the nerve plexus near the apex of the prostate. So in a video, really quickly, the truss probe is inserted in the rectum to allow visualization of the prostate. The ideal needle target is in the perirectal fat, about mid-gland, in the midline, posterior to the prostate, anterior to the rectum. Looking at the axial view, you want to be midline. Initial injection is with saline, and that's to hydrodissect, make sure that your needle is in the correct position, but also to identify that the plane is going to expand correctly and you can get an idea of where the hydrogel will sit. You do want to aspirate and make sure you're not intravascular. Exchange out the syringe for the SpaceOAR syringe assembly, then injecting that with just a steady injection speed over a few seconds, and the hydrogel is in place. And again, it's about 1 centimeter space that lasts for 3 months. Still there? Okay. So a quick video of an ultrasound procedure. Looking in the axial plane, you can see at the rectum, which is down here at the very bottom, is close to the prostate. It's about 3 millimeters. I don't know what the real measurement is. Here it's a little more difficult to see, but the prostate is here, the rectum is down here, and here's the perirectal fat. We don't really see the rectum other than over here on the right side a little bit. This is the injection of saline to elevate and develop that space posterior to the rectum. Posterior to the prostate, anterior to the rectum. And then the hydrogel injection goes in and fills that space. You can tell it's the SpaceOAR Hydrogel because there are a few air bubbles that probably get in, and it has a slightly different refractory coefficient. So you can tell when that goes in. But the hydrogel is in place, and the prostate is elevated away from the rectum. One of the major ones that was looking at patients with T1 or T2 prostate cancer with a Gleason score of less than or equal to 7 and PSAs of less than or equal to 20, and they were also kind of lower volume, so less than or equal to 50% of the cores were positive. It was a prospective randomized parallel arm single-blind multi-center controlled trial. It was a 2-to-1 spacer to control randomized in 20 sites across the United States. I'm going to skip over some of that, but basically 30%, a third of the patients only had local anesthetic, a third had general anesthesia, and 25% with MAC. Everyone, 95% got prophylactic antibiotics. Everything was placed in transperineally. This is important. You don't want to go transrectally because you're putting in a biologic agent. So you don't want to put something that could be infected and is going to stay in someone's perirectal space for 6 months and give them an abscess. The procedure itself, 99% of procedures are rated as being easy or very easy to perform with a 99% technical success rate, meaning that the gel was present after injection. The spaces post-implant were about 13 millimeters. At 12 weeks, there was still 11 millimeters, and by 13 weeks, it has started to decrease and was then 6.8 millimeters. There were no device-related adverse events, no delay to onset of radiation treatment. There were no infections, no rectal ulcerations, and 10% patients with mild transient procedure events related to the anesthetic typically. So what does this kind of mean in a pictorial form? With more space, we found there was less rectal radiation, so the dose was decreased, which corresponded with less late rectal toxicity, which was any kind of toxicity grade 1 or higher, and ultimately improving patients' quality of life. So control patients experienced a clinically significant decline in bowel, urinary, and sexual quality of life 8 times more often than those patients who received the SpaceOAR injection, and I think we'll see that again here in a second. So if we looked at the ability for dose reduction to the rectum and the penile bulb, there was a significant reduction of almost 3/4 to 74% in terms of rectal dose, and to the prostate bulb, there was almost 50% reduction in the dosing that was required to get adequate treatment. Looking at the toxicity, grade 1 rectal toxicity decreased by 75%. It was already relatively low at 9%, but now down to 2%. And grade 2 or higher rectal toxicity, which is more significant, decreased from 6% to 0, with no patients having a grade 2 or higher rectal toxicity. In terms of patient wellness and their outcomes, the declines in all 3 domains, looking at bowel, urinary, and sexual function at 3 years, so these are, considering this long-term follow-up, this is as long as they have, but at 3 years of follow-up, there was a significant difference between controls and those patients who received SpaceOAR, with a reduction from 20% to 2.5% in a one-time decline, or sorry, a significant decline, and then a 2x decline from 12.5% to 0. So really, clinical patients experienced a clinically significant decline compared to SpaceOAR. So this is similar data by one of these nice little person plots on the right side. You can see that there was 1 grade 1 toxicity out of 49 patients in the SpaceOAR group, and then there was 1 grade 2 out of 14 patients in the control group. So the odds are significantly lower of any toxicity and definitely don't exist for high-grade toxicities in patients in the SpaceOAR group. So what about reimbursement? This is what many people are also very interested in. So it's currently covered on a case-by-case basis with, by Medicare. Most private payers are paying for the procedure currently, so very recent timelines, just in July, the proposed physician fees were released. The fee schedule was finalized in November, and it looks as the Category 1 CPT code will be in effect on January 1st of 2018. Sort of in some more detail, the current code is an incomplete code as of currently. The full code is pending final release, but we again expect by January 1st to have CPT approval. The anticipated rates can be seen here for the transperineal placement of a biodegradable material with very reasonable physician office payment rates, including in the ambulatory surgery center. So they're continuing to evaluate the reimbursement and see if we increase to cover the cost of the SpaceOAR as well. in the ambulatory setting. In terms of where it's covered, the coverage decisions, there are definitely several groups that are covering this currently. The NCCN guidelines have been proposed to the NCCN to be considered in their guidelines. I don't know where that's going to stand. Will at least be reviewed and they can make a comment about it. And so finally, in terms of SpaceOAR utilization, over 50 peer-reviewed publications to date, currently used in 16 of the top 20 U.S. cancer centers based on U.S. News and World Report ratings. About 14,000 cases have been done worldwide, with 7,500 in the U.S., mostly in those clinical studies. There are 225 centers performing the procedure currently, and again, the CPT code will be effective January 1st of 2018. So really, what are the values of this? So toxicity reduction, so offering the best patient care that we can. One of the market differentiators is there's no capital outlay. All you do is you buy the kit and you get paid for it. You don't have to, there's no other hardware or equipment that needs to be purchased. It allows for SBRT, increases the ability to do dose escalation, the potential for salvage options, although that remains to be seen, and it's very easy to implement from a urologic perspective. I think one of the other things that isn't on the slide, but as urologists, we can still maintain then some involvement in the treatment of our patients who are going on to radiation, since most of us see them afterwards anyway, so it's nice to have a little more involvement in their treatment potentially. So in terms of planning considerations, and I want to thank James Yu as one of our radiation oncologists for giving me some of the radiation treatment planning slides, but we've seen that with the increase in the perirectal space, we can really optimize the planning by using higher doses of radiation than we previously were able to, and really with significantly lower rectal dosing. So some of the tables or the graphics from that initial clinical trial, I don't know if you're able to see the curves here well, but you're looking at grade 1 toxicity on the left and grade 2 toxicity on the right, with rectal toxicity on the top and urinary incontinence and urinary toxicity on the bottom. There's a significant improvement or decrease in the gray with a spacer compared to controls for grade 1 and grade 2 rectal toxicities out to 3 years or 40 months of follow-up. And in urinary incontinence, interestingly, there was a decreased risk of urinary incontinence after SpaceOAR use compared to the control groups after radiation. But when looking at grade 2 urinary toxicity, there was no difference. So somehow has a improvement in low-grade urinary toxicity as well. At Yale, we're using emerged MR and CT to evaluate where the SpaceOAR location in addition to the prostate. So we are doing combined treatments where we are actually, in addition to the SpaceOAR, using Calypso beacon radiofrequency tracking to further minimize the amount of radiation that our patients receive. The Calypso beacons, 2 of them can be seen here within the prostate. The prostate contour is the yellow line. The radiation target is the red line, and as we can see, the rectum is far away. The SpaceOAR is the white area here, but the rectum is far away from our radiation target zone. So with the addition of the Calypso beacons, instead of a 1 centimeter margin around the prostate, we're able to decrease that down to about 3 millimeters because of the improved tracking for motion. And then also with the combination of that with the SpaceOAR, we're able to almost completely exclude the rectum in almost all cases from receiving any significant radiation dose. Here is just a hot heat map looking at the treatment dosing. So again, the SpaceOAR is kind of hard to see is here. This is graded by different dosing, but the anterior rectal wall is receiving very minimal dosing. Looking at the prescription isodose line, which is the yellow one, that is not touching the rectum in this patient. And with 1 year follow-up, we really had no GI or GU symptoms in the few patients that we have done this on. So we so far at Yale have implanted about 25 patients with no major toxicities. We have minor rectal fullness, but that's really the only complication to date. Most patients are started on tamsulosin after their first or second treatment with their SBRT, and really GI side effects have been minimal. It does, however, require a special MRI protocol. That's mostly for the Calypso beacons, though, and not for the SpaceOAR. Again, the procedure is done as an outpatient with really minimal urologic follow-up until after their radiation treatment. We also have a HighRisk Protocol at Yale in which we're delivering pelvic RT with an SBRT boost and long-term ADT. These patients are all getting Calypso and SpaceOAR, and we're evaluating with this boost if what their patient report outcomes on the EPIC 26 will be measured after measuring them at regular intervals over 2 years. So far, 6 patients have been enrolled in this trial with a target accrual of 50 patients. So in summary, SpaceOAR effectively reduces the toxicity of radiation therapy to the rectum. It is easily implanted as part of an outpatient procedure. Reimbursement approved is starting in 2018, and we have embraced its use at Yale with combined between our urology and radiology colleagues. Thank you. I'll take any questions.